dental students, the one thing we always think is what are the things that are most important. And as students, all of us have thought of studying some things because we feel we really need to know them for the long term. And some things we need to know maybe to pass exams. And that happens. Yes, I know it happens. We've all been there, we've all done that. But and for most of us, of course, when we think dental caries, we think periodontal disease is there up there. But what about other diseases? And in the year 2019, there was this very interesting study done by a very well known journal, The Lancet, and they came up to say that the oral diseases had a cumulative amount of 3.5 billion people, which was at that moment half the world's population. And the three diseases were of importance. And in fact, they went on to say that the dental community had vastly failed in managing these. And it was true, it was written by dentists. We have not really made it up there as yet in terms of managing these. But that aside, that's a whole talk for another day. For today, let's think about these three diseases. And I can understand that a lot of you are going to say that that's a lot of work. 3.5 billion people requiring care. Should it really all be ours? I mean, yes, we understand the dental caries and we understand the periodontal disease. What about the rest of it? Can't we give oral something like oral cancer maybe to someone else? Should it be somebody else's problem? And is it worth the effort for us? Well, the answer to both of those is yes. And we will get to discussing that in a little while. But first, let me welcome you and thank you for joining us today. I'm Dr. Mandana Donahue. I am the founder of Oral Pathology 360, in case you have not been here before. And we have been running this for 2 years and we have asked for help from our viewers and those who enjoy watching by contributing a small amount each week. And last week, we are very grateful to have received some from Dr. Divya Upala. This is the second time she has contributed. Now, with that, let's just let me get organized and let's start. So, coming to our two questions. First question: is this really our problem? Should oral cancer be a problem for dentists? I mean, everybody else looks in the mouth, right? So, I think the first thing to say is it's all about location. Like they say, it's location, location, location. And when you think about the location, well, oral cancer is definitely our problem, considering the areas that come under the purview or are included within oral cancer: the lips, tongue, gingiva, floor of the mouth, palate, buccal mucosa, vestibule, and the retromoral area. There's no question that this is our turf. We are the people who know it best. We are the people who look most often at the part and most seriously, and it's really our problem. So that is the first question. The second one: is it worth the effort? Well, yes, you think about it, it really affects anybody from stars to politicians to sportsmen to known, unknown, well off, poor. There is no question. There is no strata, there is no population, nobody that is really left out of the purview or out of the possible range of oral cancer. And when you think about the fact that we could overcome such pain, I think it's definitely worth it. But okay, let's not just talk emotions, let's talk numbers, at least a little bit. Let's assume that these were 100 patients that were diagnosed with cancer at any point of time in any year. Say this is year zero. And then this is how many would survive for 5 years if their disease was diagnosed in the advanced stage. Advanced meaning it has spread to either a neighboring site or it's basically spread to a distant site. It's not regional anymore. On the other hand, if we had to catch the disease early, that's in the localized stage, over 80% will be cured. And note, this is cured. This is not 5 year survival. These are cured. I think the comparison is very, very obvious. There is no question that we need to catch them, we need to catch them early, and there is only one way of really catching them early, obviously, is that if we are looking for them. And for that, we need to know what they are. So, yes, definitely the outcome that can be modified by us is definitely worth it. So, what are we going to talk about today? First is going to be what is oral cancer by itself. Then the next is going to be the pathogenesis and general considerations of malignancy. Then pathogenesis in terms of oral cancer, and some risk factors and role of hereditary. This is going to be part one of the lecture series. So we will be stopping just there. So what's oral cancer? First and foremost, the name. There is always this confusion, I know, for students, because most of the time we as teachers are very strict when we say, I'm asking you what's a carcinoma, I mean what's a carcinoma, and we are very specific with names, and we are very specific with categories. Then on this one ground, we go and we say oral cancer, and we no longer mean just any tumor. In fact, we mean oral squamous cell carcinoma. So why is that? Well, the first thing is it's a matter of numbers. Somewhere between 90 to 96% of all malignant tumors within the oral cavity are squamous cell carcinoma. So that's the first reason. And that's a very specific and very well documented. Then there is one that I think is also slightly common sense. Now we all know this old thing which says a rose would smell as sweet with any other name, and I agree with that. It would definitely smell as sweet. But the question is, would there have really been a Rosa rubiginosa? Is a Rosa rubiginosa? Is a Rosa rubiginosa? And I hope I said that right. I don't think so. Really. So in this case also, while whether we say oral squamous cell carcinoma or we say oral cancer, we mean the same thing. But seriously, oral squamous cell carcinoma is not going to be able to cut the requirement of getting across. The major thing about managing, preventing oral cancer is to get the information out there. And as names go, really, oral squamous cell carcinoma, I really think we would put everybody to sleep rather than giving them or getting them involved in the message. It's just too long. So we will stick with oral cancer. And I think it's a good choice that we have so far stuck with it. Now, coming to oral cancer, the disease. First and foremost, of course, oral squamous cell carcinoma. So it is a malignant tumor. And first to say it's a neoplasm. Now, Rupert Willis defined a neoplasm very well. It's an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner after cessation of stimuli which evoke the change. This is of a neoplasm. This could be, of course, benign or it could be malignant. For it to be malignant, for any neoplasm to be malignant, now it needs to be basically able to spread. So the sign of malignancy is to spread, to invade surrounding tissues and spread to distant sites. So these are the two things as far as the name goes and as far as what the diseases goes. The next thing is, of course, it's a carcinoma, which basically tells us it's a malignant neoplasm arising from the squamous epithelial lining. And it's oral, so of the oral cavity. Now coming to the pathogenesis, and this actually applies effectively to all cancers, all malignant tumors. Part of what we want is really in that definition. It's an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissue and persists in the same excessive manner. Now, basically, some of the points that we need from this are these. One, it's an abnormal growth and it's uncoordinated. It's persistent. It spreads to distant sites. This really sums up the whole thing for malignant neoplasm. To be an abnormal growth, to be abnormal, there has to have been a mutation, to have changed things from the normal. To be uncoordinated, again, there has to have been a mutation. For that matter, even a persistent needs to have a mutation, and so does the spread. So, mutation really is a major part of this, and mitosis or proliferation that supplies the cells that are going to do all of these things. Now, this brings us to what I like to call the three M's of cancer. That's the mutation, mitosis, and another factor that's mutagenicity. So you have a mutation, which means now the cells are out of their normal control and multiply without really requiring a normal stimulus to multiply. They survive, and the multiplication continues and keeps feeding, and the mitosis itself will keep feeding the mutation too by things going wrong. And then all this pool of cells are now finally going to move. And that is the final thing that makes it possible for a cancer to develop. So, first they just spread around in the immediate area, and then finally they can go further away. That is mutagenicity. So, the three M's of cancer: you have to have a mutation, you have to have mitosis, and you have to have mutagenicity. Now, let's take it a little deeper. So, what are mutations? But they are permanent alterations of the genetic base pairs or codes. There are two major types: the acquired or somatic, that occur in any dividing or somatic cells, for example, epithelial cells, and these will affect the cell's daughter cells only, which means basically an epithelial cell that is undergoing a mutation, it's only going to be whatever cells further are developed from the division of that cell that will get affected. This could be maybe of an special area, or it could be only of a group of cells. Now, these are the most common, and they are involved in 90 to 95% of all the cancer causing mutations. On the other hand, are the second type, and these are the mutations that affect the germ cells. So, germ cells, as we know, are the reproductive cells. And by virtue of being the reproductive cells, these will be inherited by the affected individual's offsprings and affect all the cells of that body, of that person. So, this is where hereditary comes into the picture. Now, some important features of mutations that one needs to remember. First and foremost is mutations are not uncommon, because the genetic transcription, although for the most part true, but does go wrong. And so there are about 1 to 3 mutations per cell division, even on the normal types, every cell division. But on the other hand, what is interesting is to remember that they are random. So, not necessary that every mutation is carcinogenic. The next thing is most are repaired or the cells are destroyed. But when the few persist, and those are then passed on to the daughter cells. Now, since these cells form the proliferative pool, a mutation that survives will not only pass to the immediate next generation, but is also going to keep on, because it's the daughter cells. So it's going to be continuously accumulating in a very exponential format. When we think of mutations, I think, at least in my mind, this something like this always comes to mind. And yes, mutations were very important, but they really never quite as interesting. They are never going to bring in entirely new abilities to any cell. Nothing absolutely new is happening. What we have to always remember is that mutations basically are just unmasking or bringing back some existing abilities within the cell. Now we know, for example, that every cell, every between the embryologic stage and the fetal state and the adult state, there's a whole change. In the embryo and fetal states, what happens is our cells have great multiplication ability. Its multiplication is the absolute thing. But then as we become an adult, they switch over. Mitosis reduces, function increases, or differentiations and specializations increase, because within normal cells, Either the cell can be producing signals or proteins that are creating its functional output, or it can be multiplying. It cannot really do both. And this is what happens in the adult state. With cancer cells, what happens, however, is that they manage to turn back the stimuli or the setting, the code that ups mitosis. But interestingly enough, their function does not go back to that, what would you say, like almost fetal stage where the function is really very limited. They very smartly still maintain part of the functional abilities. So although part is lost, for example, they are now don't have proper intercellular attachments or keratinization in the right place, but they do have keratinization in the wrong places. So that's where we see this keratosis. Now, these are also important because that gives them a little edge to survive, because finally, just division is never going to be sufficient. Now, this barrier for going from an adult normal cell, which is dividing but also is mostly decidedly differentiated, to a stage where there is definitely more multiplication and there is very little control. There is a barrier for this, and the natural barrier is lower for cells or tissues that have a turnover rate that's very high, and which is roughly corresponds, if you see the turnover rate of cells in different tissues, you'll also find that it corresponds with the rate of malignant transformation in these. So epithelia generally are the most, have the highest rate of turnover. Like for example, the turnover rate of oral mucosa is between 14 to 21 days. So there's a physiological susceptibility because they're already set to a point where they multiply quite regularly. So multiplication is not turned off in these cells. The multiplication is still on. Now, what happens is these cells have a greater capacity of turning malignant. The next in the category is the hematologic cells, that's lymphomas and leukemias are the outcome. Then are all the connective tissues where we have sarcomas, and the least, of course, is the nervous system and the brain. Now, this is exactly where it falls in those categories. So, the higher the tissue's basic multiplication rate or turnover rate, the greater they are likely to turn malignant. And this might be for a number of reasons. Among those could be because we, of course, already said that every once in there are 1 to 3 mutations every time for every cycle. So the more the multiplication, the more the natural chances of having mutations. Now, how does it otherwise process besides what happens across the normal duration of the life of a cell? One is we could have mitogenic stimuli. Mitogenic stimuli such as chronic inflammation and any irritation. These could some chemicals. These are all mitogenic stimuli. They increase mitosis, and therefore, with the increased rate of multiplication, of course, there's going to be an increased rate of possible, it's simple mathematics, there's going to be an increased rate of mutations. But sometimes this is helped along, the mutation is helped along by mutagens. Almost everything that we say is a carcinogen is a mutagen. So, very of course, radiation, tobacco, alcohol all come into that picture. They are also all mutagens. So these now increase mutations. So the increased mitosis is feeding the mutations, and then there are actually direct mutations. And if we think about it now, with all of these, it's you think of a factory. If everything is happening slowly and well as planned, say that a factory is putting out maybe 100 units of something, it can be happening very well. But supposing you put 1,000 pieces of something in that line, everything is going to get jammed up and is going to get destroyed. So this is the same thing. Now we increase the numbers so much that the repair system fails. Now this sometimes could be just that the repair system is failing, or there could actually be an genetic susceptibility where there is already a problem with the repair system, with the gene repair system. And all of these will add, and mutations will persist. So, what actually we say mutations, and then we say they are random, so not all of them is going to cause a cancer. So, which ones will cause a cancer? Now, when we think about it, cells have their whole cell cycle is decided by a number of things. The first is proto-oncogenes are a set of proteins that come into action to start multiplication. And this is normal. Then there are tumor suppressor genes, the ones that step in and ensure they check every copy of the DNA that is created and say whether it's fine, it's not fine. Sorry, they do also act as a repair, but most of the time they just see that they are turned off, that the proto-oncogene does not keep on active. So they break the process at one point, and they are the tumor suppressor genes. For most of our body's functions, there's a loop back, there's a feedback mechanism. You need something, and they are always in reverse with each other. Something goes up, something comes down. So, and they control each other like that. There's a negative feedback. So tumor suppressor genes, maybe you can think of them as a feedback, but they also check and see that everything is working well. And then there is the DNA repair genes. These actually see that the DNA has been properly checked. They will destroy the cells that have not worked properly, there where there is a problem. They will either repair it or they will uh, destroy it. So, right, how do we go from there to this? What will happen is that proto-oncogenes are mutated to oncogenes, which are now a dominant gene. Basically, proto-oncogenes are dominant. So if there's a mutation in a single copy, we know all our genes are in two copies, but if one single copy is mutated, that will be effective in raising the number of mitosis. And the oncogenes are not inherited, they are always acquired. The next mutation is of the tumor suppressor genes, which now are mutated. These are always, or they can be either hereditary or acquired, and they are recessive genes, which means that even one is working, they will work. So as long as one copy of the gene is working, they're working. And of course, with the DNA repair genes. So all of these now have gone out of function. So what happens? Let's try and make it a little easier. One of the best ways that is often applied to explain this whole concept is talking of a car and with its brake and the accelerator, the brake, and that whole setup. So let's see what happens. Let's say today our cell is taking the genome, fired up the genome, and is going on a trip to mitosis. Right. So everything is fine, all going well. The proto-oncogenes, the tumor suppressors, and the repair system are all functioning. The world is happy. The cell is sailing along very nicely. But now suddenly, the accelerator is stuck because the oncogenes have turned on. There is an accelerator pedal that's being pushed, and it cannot be disengaged. It's just pressed down. Well, scary. But okay, still the brakes are working. The tumor suppressor genes are working. You have two brakes. The brakes are working. So it's scary, but nothing to really go totally crazy about. Then little down the line, and the brakes fail. Definite cause to worry. So now you are speeding, and your brakes have failed. The suppressor genes or the brakes have failed. Still okay. If you're on a flat road, there's no extreme stimulus to keep multiplying, and your engine is working, so you can use the engine to slow yourself down. In this case, the engine being the DNA repair genes. But things are really going to go wrong when you find on your way further down the road that you're going downhill, Your accelerator is stuck, your brakes don't work, the engine no longer responds because now the DNA repair genes have also stuck. So there is really nothing that happens there, and there is a malignant transformation. So this is the a very nice analogy that is there for explaining this. I hope it helped in explaining it to you. So a little more scientific detail about the oncoproteins. When they cause cancer, they do so by enhanced cell division. But they also do one more thing, they cause inhibition of cell death. They have environmentally induced gain of function mutations, typically occur at specific sites that increase action of the target protein. So there are three ways that this can happen. One is they could have a chromosomal rearrangement that causes an excess of the normal oncoprotein. The next is there could be a point mutation within the control element of the gene, which produces an excess amount of the proto-oncogene. So these are still not really gone totally wrong. But now there could be a mutation of the whole gene itself, which produces an abnormal oncoprotein. Now the oncoprotein being produced is no longer normal, and it has an enhanced and longer activity. So basically, it is being produced extra, and it has now an increased activity and a longer duration. And tumor suppressors, they are genes that normally limit cell growth, but they also do other things. They monitor the speed of the cell cycle, they repair mismatched DNA, and control the timing of apoptosis. Now, these mutations may be acquired or hereditary, but the hereditary are very rare. And these occur at multiple sites. So numerous mutational events may promote one gene loss or dysfunction. Then the last system is the DNA damage repair. These fix mistakes made when DNA is copied, especially during the G2 after DNA replication and before the chromosomes divide. Repair genes mostly correct DNA faults by nucleotide excision and mismatch repair. These are the two main ways that they actually ensure that this corrections take place. Now, these damage could be single strand or double strand. When it is single strand, it's very easy because what tends to happen is that you have the other copy immediately close, so there's a comparison is easy. But on the other hand, when both the strands have got a fault, then there is a problem. So what the DNA repair genes do, the system does, it actually makes a framework, brings back these pieces together on that framework, matches them, and then removes the parts that are damaged. What is interesting is that many of these actually fail to function not so much because of mutations, but because of such things as epigenetic silencing, which we will talk about a little later. And many of these genes also function as tumor suppressor genes like P53. So, coming to the genetics of oral cancer, this is a typical uh, genome of a normal female karyocyte, and then there is one of a head and neck cancer cell line. Now, if you just look at this, and it's like way out there, I think there can be no doubt that the one on the right is abnormal. It's almost completely triploid, and there are deletions, there are additions, structure abnormalities. There's a whole lot of things that are wrong with that. So that tells you there's a lot of. This is an example of what it could be. Of course, not every case will have this many, and not every case will have. I mean, some may have more, some may have less. So in the oral cancer, coming to oncoproteins that are actually applied or of relevance to in oral cancer. So what do we have? We have the epidermal growth factor is one of the proto-oncogenes that belongs to tyrosine kinase receptor family. The other members include ERB2, HER2, NEU, and a recent analysis has revealed that about 2.8% of oral cancers carry mutations in the tyrosine kinase domain of EGFR. So this is one of those which is directly relevant to oral cancer. The other one is RAS, that is a rat sarcoma virus. It's an intracellular cell signaling molecule, and its pathways involve cellular proliferation, migration, adhesion, and differentiation after growth factors. It's a signaling pathway and is frequently mutated in oral cancer. It is also frequently mutated in a number of others, actually, but it is very much there in oral cancer. And it is very highly linked to smoking and betel quid chewing. Now, in oral cancer, the tumor suppressor that is most important, and actually it is important in most cancers, is TP53. Now, tumor protein 53 is considered as the guardian of the genome. The activated form, P53, is a DNA binding transcription factor that facilitates apoptosis or induces cell cycle arrest. That's what it's supposed to do. It also activates DNA repair mechanisms. And it is found to be mutated in 40 to 70% of all oral cancers. So this is another one which is very relevant to us. The next one is retinoblastoma gene. Now, this has been one of the very first ones that was identified. And it is involved in the regulation of the cell cycle and its differentiation at the G1S checkpoint. It is mostly lost due to loss of heterozygosity, or what we call as LOH, and is seen in 17% of all the oral cancers. It has four other members in the family: cyclin-dependent kinase inhibitor, cyclin-dependent protein kinases, D-type cyclines, and transcription factors, E2F family. Now, germline mutations have been known in the cyclin-dependent kinase N2A, and these carry a higher risk of oral cancer and melanoma. And we said that the germline mutations are rare, but this is one of those cases where it is there. The next one, of course, is in the DNA damage repair system. And as far as the oral cavity cancers go, most of them are the mismatch repair system that goes wrong. Associated protein MLH is often affected, and there is a genomic stability. They affect genomic stability and lead to the formation of small, unstable, repeated sequences of DNA, which are called microsatellites. And this supports oncogenesis. Now, very important in this is that, like MLH, is more often silenced due to epigenetic silencing. We are back to epigenetics rather than actual mutations. So, now coming to what is epigenetics. When you think of epigenetics, you have to think about it as the conductor. If you think of the genome as an orchestra, with each gene very well informed and very well trained as to how it should learn and how it should manage. So each one is already decidedly capable of playing their own piece of music, or in this case, creating their own protein. But for it to actually become a cohesive symphony, you need a conductor. So epigenetics is the conductor to the symphony of the genome, and it guides what needs to be done next. Because generally, if you think of the genome, it is so vast that you can't just pick it up and read it and duplicate all of it, or decide. You have to know which part needs to become active when, and that happens thanks to epigenetics, which are chemical tags that alter the gene expression and determine the cellular phenotype. So, two things they do. At any time, they decide what is to be expressed, what is not to be expressed, and therefore, by definition or by default, they decide what is the phenotype of the cell and what it's going to do, obviously, what's going to be its product. We know that the structure of a chromatin consists of nucleosomes. These are each composed of DNA that is wrapped around histone proteins. And how wrapped they are decides whether they can be read or not. And this is modified through epigenetic mechanisms that are mainly divided into three types. There is DNA methylation, histone modification, and non coding RNA related modifications, especially within the microRNAs. Now, histone basically decides which sections of the DNA become accessible for transcription. So, when it unwinds, it allows that section of the uh, DNA to become accessible for transcription. The other thing is methylation. Now, expression of genes is allowed through methylation, where methylation silences a gene and hypomethylation activates it. So, if you want a gene to begin to express, it should not be methylated. And when you want it to stop expressing, it will be methylated. So, this is how silencing and activation of genes takes place. MicroRNAs target and inhibit translation of specific genes. They are single stranded non coding RNAs, which are approximately 20 to 23 nucleotides in length. They are encoded in the genome, function in RNA silencing, and post transcriptional regulation of gene expression. They function via base pairing with complementary sequences within the mRNA molecules. So, which means that a single change in one microRNA can affect hundreds or even thousands of protein expressions because they are functioning at a higher level. Another interesting thing about the epigenome is that it's highly accessible to external factors. And while generally, obviously, you cannot have an access directly to the genome, but the epigenome can control the genome. And most often, when we talk about mitogens, especially where we are causing increased mitosis, it is thanks to the epigenome. The epigenome is just the one which is bringing it about. Now, tobacco use has been linked to non specific global hypomethylation and therefore oncogene activation. We said hypomethylation is activation. So it goes and has a non specific global hypomethylation, and that brings about an activation of oncogenes. In contrast to smokers, patients who drink heavily have an increased risk of hypermethylation of multiple OSCC related genes. But these are not oncogenes, these are deactivation of the tumor suppressor genes. So, for those who consume a lot of alcohol, that is a different mechanism. Then, inflammation of the oral mucosa is another risk which can also modify the methylation status of various genes. And of course, HPV is another one because it causes a disturbance of the microRNAs. Now, what is interesting, of course, is because epigenome is accessible to the external factors, it means that it can also be influenced in a positive way. So, if you have a healthy lifestyle, if we can remove inflammation, if you take a HPV vaccination, all of it can help in reducing those or removing those effects because they are still not in the genome, they are only in the epigenome. Now, here are some of the epigenetically regulated genes with their implications in the oral cancer. And what is very interesting to see is that only one, survivin, is an oncoprotein. Almost everything else is either a cell repair mechanism or is a tumor suppressor, and they are deactivated. So this is where actually in head and neck, even the mutations, now this is the epigenetic control, but even the mutations that take place are mostly in the tumor suppressor genes. So this is sort of going hand in hand with that. So wrapping it up till now, where we have reached, carcinogenesis requires that there be a mitogen because mitosis is required. There be mutations, so a mutagen, mutations are required. And these have to cause multiple persistent hits or mutations that take place on the genome. And these have to accumulate so that that same cell will eventually continue getting more and more faults. And these cells have to multiply. But that alone is not going to bring about a carcinoma. The cancer requires further things. One of those is that, of course, it needs a promotive epigenetics because one thing we should remember, epigenetics are also equally involved in the management of the environment. So whatever nutrition, uh, vascular supply, all that is also in a lot of ways controlled by epigenetics again. So we need a promotive epigenetics. We need a supportive microenvironment. Obviously, now so many cells are more, obviously, we need more supply of blood vessels, new blood vessels, in fact, will need to form. So, new oxygenation. So, all this is means we need to have a supportive microenvironment and we need a permissive immunity. Immunity, immune cells should not come and destroy, make it their job to go and destroy these cells. And all of this is very interesting because there is another final factor that is required, or rather, two final factors that are required. One of them is stemness. You know, this cancer has now accumulated enough faults to go on and multiply. But at the end, what if those cells, those particular cells that have accumulated those number of faults die? I mean, every cell dies finally. And also, how do you control the rest of the surrounding tissues to support you? This is where the property of stemness is required. Stemness is something that is normal again. It combines the ability of a cell to perpetuate its lineage and give rise to differentiated cells and to interact with its environment to maintain a balance between quiescence, proliferation, and regeneration. Also has a high capacity of renewal. So that was the first part is all what happens in the normal. But cancer cells with which acquire stemness now can use all of this in their own favor. So they can not only go on multiplying, they have a perpetual lineage, but they also can differentiate whenever required, as we see very often in cells where we say there is a transition, epithelial mesenchymal transitions, and back. They will also be able to interact with the environment to make the environment support them. For example, normal fibroblasts actually are anti-carcinogenic. They can prevent carcinomas because they do not allow the cells to invade. They do not allow the cells to move. So that, of course, does not help the cancer. So instead of that, it needs to be able to now control and bring about a change in the surrounding, say, fibroblasts or even macrophages. What we call then cancer associated fibroblasts, cancer associated macrophage, is because these cells have now, the cancer cells have developed the ability to actually modify the surrounding cells. And this is what gives them the next ability. So now not only they can renew, they can decide in what ways they want to go, they can control their surrounding, they have a plasticity to keep changing back and forth from mesenchyme to epithelial mesenchymal transitions, and they also can repair themselves. And With that repair, now what they do is they can maintain and promote the clones which have the strongest adaptability for survival and regeneration. So, yes, we've already went through this. The very interesting one, which is still here at the end, is that they can decide to turn quiet, to stop activity at times of high stress. Now, this would be typically what can happen, say, when we are radiating a tumor, there is stress. But because of oxygenation stress, the cells die. But and free radicals causes the cells to die. But what happens here is these cells actually begin to go into a silent mode, inactive mode. So they do not require a lot of oxygen. They do not really have a high activity, and therefore they survive while the rest of the cells die. Now, coming to the last one. Now, you have a cell that has accumulated all the harmful mutations that it could want. And you have that cell has now even managed to control the surrounding. And now there are these group of cells that are the chosen. Like I said, it can actually choose and promote the most harmful cells. So now what? What if those cells die? I mean, all cells die. But that doesn't happen to them because they have also gained. The last thing that they gain is the ability of immortality. Every cell has a limited life cycle. For that, we have telomeres. Now, these are like our cells' biological clocks. They are at the end of every DNA. And every time there's a division, they become shorter. And eventually, of course, they will be so short that the cell will stop dividing and, and the cell dies. But cancer cells manage to overcome that by activating something called telomerase reverse transcriptase gene. This prevents senescence. So essentially, now they are also immortal. So the worst of the cells with the worst abilities will continue to live. Now, this is a very well known schema and it presents the 10 hallmarks of capabilities that are considered to be necessary for cancer. Among those, of course, is sustained proliferative signals, evasion of growth suppressors, resistance to cell death, replicative immortality, induction of angiogenesis, activation of invasion and metastasis, avoidance of immune destruction, deregulation of cellular genetics, genome instability and mutation, and tumor promoting inflammation. Now, all of these are now either handled by the mutations, which have given the cells the power to multiply, to survive, to bypass all checks. And the mutations also give them the ability to move because now they are not any longer doing what they were supposed to do. So they have developed the ability to actually break away from each other, which is something epithelia are supposed to do, and they move. Epigenetics support this in multitude of ways by providing the background and providing, again, helping the mutations and also providing the environmental support. And the cells having gained stemness again gives them the ability to do all of these things because now not only they can resist death, they can survive, they can control their environments, they can, because they can also modify immunity, they can avoid immune destruction, and they can also move. So literally they have everything covered. Now, we talked about so many things about the things that can cause, and we are all quite aware of these most common risks for oral cancer, the things that can cause the mitosis and the mutations. First is, of course, age, that is normal. The next thing is chronic inflammation. Like we said, it helps by by modifying mostly the epigenetics and, of course, by increasing the rate of multiplication of cells. Graft versus host disease is one of those things which has been considered as causing a lot of tendency towards developing cancer. Lichen planus, I really still stay on the side which says I don't believe lichen planus can be a part, but it is still there. So more and more everyone says that those which look like lichen planus are not lichen planus, are lichenoid lesions, but nonetheless it's still there. Then there is, of course, our typical areca nut, tobacco. Both of those have been beyond question for the longest time. Alcohol, there has been always a little bit of question. But first, we were saying that it is only synergistic and it only additive. However, I think last year it was added as being definitely carcinogenic. Then there is radiation, both UV and X ray, ionizing radiation. And then there is hereditary, certain conditions like Fanconi's anemia or dyskeratosis congenita are really very highly increased chances or increased rates of cancer. So, is hereditary really a factor in oral cancer risk? We all know that some years back when Angelina Jolie went and got a double mastectomy done, it because she believed or because it was proven that she has a high risk, it became a question how much is the risk, hereditary risk in different cancers, and it became a great point of discussion. So, what is there a hereditary risk for oral cancer? Yes, there is a variable risk when a first degree relative of an oral cancer patient has cancer. So there is a 1.1 to 1.2 is the cancer, has a chance of cancer. Then we have those whose relatives have upper respiratory and digestive tract tumors also have a higher chance of developing second primary cancers. So this is an odds ratio of 3.8. Also, if there are numerous numerous cancers, right? These are the general other indicators. If there's a for a patient, there's a young age of onset. If the patient has multiple oral cancers in the family, and there are two or more relatives with a rare cancer, three or more relatives with a common cancer, or multiple primary tumors in one person. Now, these are all indicators of a cancer, inherited cancer risk, and I guess the rest of the family can consider getting a genomic analysis. However, the question always remains what do you do after that? Besides just ensuring that you reduce the chances of your exposure to the risk factors, there's really nothing more that we can do. Nonetheless, it's information. So, coming to incidence of inherited and sporadic forms of a tumor, this is just for the comparison. It's the last one. So, how does it work? Now, if there is no external and there is no inherited, so basically you just have intrinsic mutations that happen, like we said, while cells divide. Normally, it just takes a very long time for this possibility of a cancer to progress, which is why those are normally in old age. That is very, very common. Then you think of the second one where maybe there is no inherited, but there is a certain quantum of intrinsic, which happens in everyone. And then maybe there is some extrinsic, maybe smoking, maybe tobacco chewing, any number of, or maybe a combination of those factors. Then now the risk has, as you can see, reduced the age because obviously the end result of the required accumulation of uh, mutations is fulfilled earlier, and now the patient is maybe in middle age or early middle age. And then now we have one where there is a hereditary component. So if there is a hereditary component, you can assume that the cells have the first hit, the first change at birth itself. They have already been all affected. Maybe a tumor suppressor gene is damaged or a DNA repair gene is damaged. So now what happens is the combination of intrinsic and extrinsic, and for that matter, even without the extrinsic, obviously the chance and the chance of getting a cancer increases and the time span is shorter. So it happens at a much earlier age. It can even happen in childhood for some cancers. So this is the last slide as far as the pathogenesis go. And today's talk. To summarize, what did we learn? Two things. First is that it's a very important problem because, of course, it is something that we can make a great difference to. So we need to do our best. And not doing it leads to death, which is quite disastrous. And obviously, we cannot allow that to happen. We need to know, and we need to know it well. We need to know oral cancer well beyond what we would say just learning it to pass an exam. This is one of those things like dental caries, like, like how do you handle a cavity? How do you treat a periodontal problem? This is about as dentistry as it gets because there is no question. This is very much in our area. Nobody else looks at the oral cavity the way we do. Nobody else has the knowledge and the expertise to deal with it or with any changes of the mucosa as we do. So, this is really very much our turf. We need to know it and we can make a great difference. So that is the first thing. And of course, the cancer is of all the oral regions. Then, when we say oral cancer, we do not mean all the various malignant tumors. We mean only oral squamous cell carcinoma. Because most are oral squamous cell carcinoma, the name has stayed also, thankfully, because it's much easier to say oral cancer than oral squamous cell carcinoma. So for messaging, it makes a difference. Three things really need to happen is you need to have mutations that take cells out of their bounds, normal bounds and controls, which means now they can multiply at will or maybe just continue multiplying. If there is anything wrong with them, that is no longer corrected so that mutations can persist. And uh, the next thing is, of course, all this mutation leads to cells that can do things which they should not be able to do, such as move around and therefore cause the hallmark of malignancy, which is metastasis. By moving, these cells can move and go everywhere else, the ability of mutagenicity. And mitosis at the end is what is going to keep feeding the number of cells, the huge number of cells required for a cancer to go on. The epigenetics have to be favorable and often support a cancer because right from its development, because especially when it is habit related, it is supported by the habit itself because most of the epigenetics are moved in such a way that smoking, tobacco, areca nut, alcohol, radiation, so all of these things, infections, all of these things bring about moves where they will activate parts of the genome that bring about multiplication and also suppress the parts that are reparative or um, suppressive. So again, they move along towards a cancer. So these are the basics of the pathogenesis of oral cancer. This, like I said, this was part one, which means that the next time that we have such a lecture, we will go on to the pathology and the signs and symptoms and the diagnosis. Coming to next week, we are having another live session, which is on rare salivary gland cancers. It's a case based discussion by Dr. Neda Karduni from the Tehran University. It is at our usual time, the usual place, and I hope you will join us. With that, let me say bye. Bye, everybody. Thank you so much for being here. Thank you. Bye. See you next week.